Good evening, everybody, and welcome to our Meet the Consultant. As you'll have seen from the home screen, our consultant tonight, our professional, is no mystery. So, Alan, thank you for joining us again tonight and for giving up your time. We've got lots of questions, obviously, that we're going to be putting towards you. First of all, can I just remind people, if you can make sure your screens are off, microphones are off, so that therefore nothing comes through. This is being recorded tonight, so that if there's something said that you think, oh yeah, I missed that bit, you can look back on it and obviously go to our YouTube page, have a look, or go and visit our website, because that's where all our videos are of the past. But please, if you do go to YouTube, please make sure you like all our events, or certainly our videos, so that and obviously they keep getting promoted, and then obviously when people search more for them, it's more likely to come up as being the first hit. Obviously, speaking of our website, please do look at our website for future events. And right at the end, we always ask, but it is really important to us. We have a Q&A, and we have questions, and we have a evaluation at the end. If you can fill that evaluation in and put in lots of ideas about what you want us to do, then obviously it helps us to guide us to what we can do in the future events. And obviously all our future events are all on our website anyway, so you can see all those. So let's get started, because we've got quite a lot of questions. So the first question is, how can I better manage respiratory issues?
That's a difficult one. What you need to do is find someone who understands what's wrong. And there are not many people. The big problem with people who have the respiratory issues with TOF or OA is that the doctor doesn't really understand what's going on. And they'll try and diagnose ordinary respiratory illnesses like asthma or COPD and get frustrated when the tests don't turn out to be positive. I think you need to be a professional patient. You, the person with the condition, right? And you need to know more about your condition. But you can't go along and tell the doctor, you must listen to me, and this is the way I need to be managed. You need to gently educate the doctor. Even consultants in the hospital don't really understand cough. So I got into cough, many years ago. My first paper on cough is in the Lancet in 1987. And so I've been working at it for years. And over that period of time, we've got to know or understand more and more about cough. So cough is just one part of the spectrum of symptoms that people get with TOF or OA. I'll use the word TOF since it's what we call ourselves in this society. So the problem is that people develop a hypersensitivity. It's like having a burn on the skin. If you blow on it, it hurts. The same is happening in the throat of people who develop this cough. And the origin of it, of course, is in the esophagus, the gullet, right? Because in a TOF, the O is esophagus, and the repair of the TOF or the OA involves joining the two tubes up together. And okay, the tubes are anatomically joined up together perfectly well, but it doesn't function very well. Often there is a gap where the tubes have been joined because the nerves and the muscles are no longer working very well. So things get stuck, and that's sticking or dysmotility. So the movement of the swallowing. The swallow starts at the top and goes down gradually into the stomach. When you've got a TOF, you have a pause there and things get stuck and irritate the nerves. And that irritation of the nerves comes across all of the nerves. So it appears that it is a tickle in the throat, for example. One one of the commonest symptoms people get is throat clearing as well as the cough. Most patients with a TOF will have dysphagia. They have difficulty in swallowing as well as the cough. But the difficulty of swallowing is the food or liquid sticking at that junction of the pipes. So although the anatomy may be solved, the pipes are joined up, there is a disruption of the wave pushing the food back down into the stomach or the liquid. Also, hiatus hernia, that's where the stomach has slipped into the chest, is also common in a TOF, right? So you've got a number of abnormalities related to the esophagus. The esophagus may be anatomically relatively normal now, but it's not working very well. And this abnormality of movement becomes the hypersensitivity. So patients with hypersensitivity, and it's called cough hypersensitivity, they often get set off by things from outside. So strong smells, bleaches, perfumes, cold air, deodorants, air fresheners will set them off, and it's because the nerves have become hypersensitive. But you go along to the doctor, and the doctor really doesn't understand this, because this cough hypersensitivity is a fairly new concept. It's only been around for about 15 years now. And the doctor will be desperate to find out the cause of the cough. Well, cough is the cause of the cough because of this hypersensitivity, but they will be looking for other conditions like asthma, like COPD, like bronchiectasis. That's not to say patients with TOF don't get those, but the main cause of this irritation that the patient gets is due to the hypersensitivity, and the doctor doesn't understand that. So many investigations are done quite unnecessarily. You need to check on your lung function, and because TOF is associated with some chest wall abnormalities, sometimes you don't get a full lung function tick on the report, but it's not the cause of the cough. The cough is caused by this hypersensitivity. And getting that across to the doctor or the nurse that it isn't asthma or bronchiectasis. I was at the TOF conference in Turkey recently, and they showed some slides, and one of them was saying, look, there's a bit of bronchiectasis, and it was a tiny little bit of bronchiectasis, which is what dilated breathing tubes, right? And it wasn't the cause of the cough. The poor patient was having this cough hypersensitivity. So getting that concept across to the doctors that it's an abnormality of the nerves rather than the breathing tubes, and that abnormality is treatable with various things, which I'm sure we'll go on to, but its underlying problem is because the gullet isn't working very well. The esophagus is not working very well. Functionally abnormal, but anatomically still a tube joined up.
Thanks for that answer. It's a great one. So how would you recommend managing day-to-day when struggling to cough up sputum?
Well, I think from that question that they feel as though there is something there, and they're trying to cough it up, but nothing's coming. And that's because the nerves are irritated. It's the sensation that there's something there, and you feel as though you have to cough and cough and cough and cough, and then a tiny little bit of mucus comes up, right? But it's the sensation that there's something there. People will often say, oh, it's just there, doctor. I can't get it up, but there is nothing there, or a very small amount of mucus. So it's a sensation that you get because of the irritated nerves. So it's not necessarily that you can't get it up. It's the fact that you feel that you can't get it up. It's a real sensation, right? But it isn't due to mucus being trapped. There are some people with a TOF who have a bad bronchiectasis where they've aspirated and stuff has gone down the wrong way. So stuff comes back up and goes into the lung and causes the bronchiectasis. And they usually produce a considerable amount of phlegm. So a cupful or at least a half cupful of phlegm a day. Often it's colored, right? But most patients with TOF that I've come across, they have this dry, tickly cough and produce a small amount of mucus. So it's the sensation rather than and it's not the inability to bring up the phlegm.
As an adult TOF, OA TOF, I don't have many chest problems. Do I still need to take extra precautions, such as like the flu vaccine or COVID vaccines?
Well, if you've got relatively normal lungs, as this correspondent obviously has, you're not at any greater risk than anybody else from flu or COVID. But having said that, I mean, COVID can be quite nasty, and so can flu. And in fact, I lost a number of patients who come in, often young patients with flu. So flu is a very important problem. However, does the flu vaccine really work? Well, I'm in two minds. I mean, I don't usually have a flu vaccine, but the government recommend it. But I think it's there to protect the health minister rather than our health. So when everybody dies in a flu epidemic, they can say, well, we've done everything. We gave them all flu vaccines, but they still died. So it's up to you. And the government would recommend that you have a flu vaccine. COVID vaccine, I have. I don't have it as regular as I did when the COVID was raging, but every other year I have a COVID vaccine because you can I got a very sore arm last I had it, but that's really the only side effect. And nowadays, apparently they're restricting who can have the COVID vaccine. People are having to pay for it privately. If you're in the risk group, which is older patients, then you'll get it for free on the National Health Service. But if you go along, don't rage at the GP's receptionist saying, because you don't fit into the criteria. It is protecting the elderly. It's predominantly old people who die with COVID. So the average age of death during the pandemic was 84. That was the average age of death. We all know young people who have died from it, but it was predominantly the elderly who died. So it's quite right that we protect the elderly, and I'm elderly myself, so I'm protecting myself.
Okay, we've had a question in the chat which sort of follows on from what we've just been talking about, the COVID vaccine. And it's about, somebody said about their 18-year-old daughter has chronic lung disease and only 50% capacity, and now no longer meets the criteria for the COVID vaccine, but they have had the flu vaccine. Is there any advice, any exceptions, or that you could offer? Or should they take it? Should they not take it?
Yeah. She's lost about an amount of reserve from her lung, right? So we have our lungs are, over capacity. We can run a marathon, right? When you're well, but when you get chronic lung disease, you will develop a reduction in that reserve, so that if you get a little bit on top, and as I say, both flu and COVID can be quite dreadful, but younger people have much less likelihood of having severe lung disease from COVID. I mean, most children, for example, went through the COVID pandemic without actually having symptomatic COVID. They were the ones who were passing it around at school and not noticing it. Right? So younger age group is a good predictor of not getting it because the immune system will fight it off. If she's had previous COVID jabs, then there will be innate immunity. The immune system will have been hiked up. The problem in old people is that the immune system dies away very rapidly, whereas in younger people, it keeps active for much longer. So it's up to you. You probably have to pay for it because, the GP receptionist will tick through those boxes and she won't have those boxes ticked. But a younger person, even with a reduced lung capacity, is most unlikely to have a very severe do of COVID.
Okay, that's great. Thank you.
Because in TOF, it's not the immune system that's wrong. It's the gullet, the esophagus, which is wrong, and that's irritating the nerves. So the symptoms you get are due to the hypersensitivity. It's not a defect of the immune system.
Yeah, I understand. Yeah, it makes sense. So one of our old favorite questions has come up again today. Which medication would you recommend for an adult OA TOF cough? And also, is Gefapixant, if I've said that correctly, now available in the UK?
Two questions there. First of all, it's a disorder of movement of the esophagus, as I've explained, right? And our best drug for treating that, it doesn't work in everybody, but our best drug is a drug called Azithromycin. I believe we've got a question later on about Azithromycin.
Yeah. What's the next one?
All right. So Azithromycin is an antibiotic, and it was a very commonly used antibiotic, and we're not using it as an antibiotic, though. It has another property in that it improves the movement of the gullet, right? And so if you've got a defect of motility of the gullet, azithromycin, it is a mimic of the hormone motilin. Motilin controls the movement of the esophagus. Right? So it goes when you take your azithromycin, and that's 250 milligrams once a day. Some people get a marked improvement in the motility. In other people, it's a bit like flogging a dead horse, but there are other things that you can do. So azithromycin would be my recommendation. One tablet, 250 milligrams once a day, and after a month, you'll know whether the cough is diminished or not. So if your cough gets better on the azithromycin, insist to the GP or whoever you're going to see that you carry on with it, because I've had people on it for years and years and years. In fact, I had a lady the other day who'd actually got COVID, and her cough returned. And I said to her, "Well, you're on the azithromycin." "Yeah, my cough's returned despite the azithromycin." I said, "But you've been on it for years. What happens if you stop it?" She says, "The cough comes back within a few days." So you can carry on with the azithromycin lifelong, really. Gefapixant. Yeah, you muted again, Duncan. Gefapixant is
Sorry.
Gefapixant is the new kid on the block. Gefapixant was developed to treat chronic cough, right? And what happens is there is damage to the lining of the airways, and that releases substances which latch onto the nerve and irritate the nerve. One of those substances is the compound called ATP, and ATP binds to a receptor on the nerve, P2X3, and that receptor is blocked by gefapixant. So the irritation doesn't get through to the nerve. And so the nerve doesn't send the signal to the brain, giving you that tickle and making you cough. Unfortunately, for the drug company manufacturers, MSD here or Merck in America, the FDA turned it down for licensing in America, where they make the money on the drug. So they've been rather reluctant. It does have a license in the UK, though, and in Europe. And so doctors can prescribe it. Unfortunately, many of my colleagues are reluctant to prescribe it, but I've been prescribing quite a lot of it. I prescribe it via a private prescription, and because the NHS, the manufacturers never put it through the NHS NICE procedure to get approval. So my patients get a private prescription, and they have to pay £120 per month for the initial prescription. After that, they tend to take it as required. So we have people who will only take it when they're going out on social occasions to prevent a coughing attack when they're in the theatre or cinema. Other people, food sets them off. So they will take it if they're going out to a restaurant. But other people, I've got another lady who's a solicitor, or rather a barrister, and she has to go into court and speak, and speaking sets her off. And of course, coughing over the judge is not a very good way to win a case. So she rings up and absolutely insists we send her the Gefapixant prescription. You can buy it in the supermarket pharmacies. Aldi and Morrison's are probably the best, because they charge an extra prescription fee, and it depends where you go. But Aldi is cheapest.
I believe. Somebody's just asked if we could spell Gefapixant, so I'll just go through it. It's Gefapixant.
Yeah.
If I've got it right. So it's Gefapixant. So one person just asked for that. So coming back to azithromycin and daily doses, somebody takes it daily and has found it very helpful. However, they're struggling with their digestive issues in the bowels and stomach pain, constipation, diarrhea. I wondered if there's anything that they could do to help these side effects.
Yeah, that's a very good question. As I said, it works on the movement of the gut, right? And GI upset is the commonest side effect. Just showing you what the effect and side effect is. So the lower bit of the gut, where the gas bloat occurs and the constipation stroke diarrhea, it has other receptors that we can target. And there is a drug called prucalopride. Prucalopride is licensed for constipation, and unlike the other laxative agents, it actually targets the movement of the gut. So I've been using this drug, prucalopride, 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 and it is a licensed drug. You can get it on the NHS, and it's 1 tablet a day. And that has proved very remarkably relieving in some patients. So you take the azithromycin to improve the movement of the gullet, and then you take the prucalopride to make sure that the rest of the gut is working.
Okay, that's great stuff. I know my own daughter might be interested in that, so I'll pass that information on to her. Our next question still carries on from the PPIs and long term. They're asking about the usual questions about what are the long-term effects from PPIs and taking them. There's other side effects, or could they actually just take PPIs on an ad-hoc basis and they'd be proved to be just as effective?
Well, depends what the GP is prescribing, or whoever's prescribing the PPI is prescribing it for. So that if you've got a hiatus hernia or esophageal dysmotility, this poor movement, often the doctor will automatically prescribe the PPI because they're harmless. Well, in fact, they're not harmless at all. Right? They cause, I've seen ladies who's lost their hair, for example. Osteoporosis is a common side effect. It also causes GI upset. In some patients, it actually makes the guts worse rather than better. And I take it as required. So if I have an episode of heartburn, I will take the PPI. The problem with it is that it takes about 2 hours to work if you're taking it for heartburn, right? So I advise patients usually to take it as required rather than as a prophylactic agent, because they have the idea that it protects the stomach. Well, there's not very good evidence that it does protect the stomach, but take it as a symptomatic relief. If you're having a lot of heartburn, by all means take it regular. The way to take it is first thing in the morning with breakfast and at tea time. because with food, it gets about a third more into the bloodstream. So don't take it, willy-nilly, in the middle of the day or last thing at night, which some people do, because it doesn't work very well. Take it with breakfast and with your tea in the evening. That way you'll get maximum effect. Twice a day is probably more acid suppression, but you're treating acid. You're not treating reflux. PPIs do not treat reflux. They treat the acid. You reflux just as much, and it's the non-acid stuff that comes up and goes in your lungs and irritates the gullet on the way, giving you rise to this cough hypersensitivity.
Yeah, that's fascinating. By the fact that you're saying that take it with a meal, so it gets a third more into your bloodstream.
Yeah.
Didn't realize it was such a high figure.
No, it's well. If you read the leaflet, that's what it says.
Personally, I don't take it, so but my daughter does. Right. So moving on to the TOF cough. Can you suggest any breathing or swallowing techniques which could help to reduce the cough?
Yeah, there are some speech and language therapists are able to provide you with techniques which help reduce the cough. And one of them is put your head down and swallow, and that produces the movement of the gullet, which then gets the stuff going down rather than coming back up or irritating the gullet directly. So that's one technique that I know of. But I think the major effect of the speech and language therapists is the fact that you're talking to someone who understands something about your condition. I went to the European Respiratory Societies last week in Amsterdam, and there was a series of fascinating talks. In fact, cough is held with the brakes on most of the time, right? But some people lose their brakes, and this is why drugs like morphine work, because they replace the brakes up here and reduce so the signal comes up from the lung or from the gullet, ends up in the bottom part of the brain, which then goes up to the midbrain, and that's where the gate is. So the gate is shut by this effect from the cortex up here, the top bit of the brain. And some people, when they have someone to talk to and someone explains what's going on, this cortex reduces the amount of signals that are going through from the gate. And that's why there's a big placebo effect with some of the drug trials that we see, because for the first time, someone's talking about their cough to them and understanding it with them. And so being relieved of the idea and understanding what's the cause of the cough is a great relief to some people. And that reduces this, or shuts the gate to prevent the signal getting up and giving you that tickle. I mean, it's a bit complex, but, there is this mechanism which we recently discovered showing with brain imaging. You can actually see the areas in the brain lighting up and then being turned off by this effect from the cortex. So being reassured that your cough is not going to kill you, being reassured that the cough we understand, we may not be able to do a lot about it, but actually that reassurance is the thing that people, I think, get better with. So there are techniques, but the number of speech and language therapists who are able to give you that correct advice as opposed to sort of generic stuff is relatively few.
Oh, that's great. Brilliant, thank you. So how common is it for adult OA TOFs to develop a TOF cough, and does it ever improve naturally?
First part of the question is that it can go. So it In some patients, it's just a complete pain in the neck all the time, right? But in other people, it goes up and down. So, as I've said a few minutes ago, there is a component from the brain which also alters the cough signal. So you can have an anxiety state where the patient has some life event and they're anxious, and that increases the amount of coughing. So anxiety is linked. Also, change in eating habits can also alter it. Some people go away on holiday. Even the weather can affect. So I've got a gentleman who was born in the Middle East, and when he goes home, his cough goes away, right? And when he comes back, as soon as the plane lands in Manchester Airport, he starts coughing. In fact, he told me that it was when the bag went round the carousel that he started his coughing. So temperature and humidity also influence it. So there is a number of factors which influence this cough because it's a nervous phenomenon. It's not, it's all in your head nerves, real nerves.
Okay. I'm just going to nip to the chat again because we've got a question in there which sort of follows on from the TOF cough. And somebody's put down that they get prescribed, if I pronounce this right, Elvasan or Elvanse, which is for their ADHD several months ago. And they started taking 20 milligrams daily, and they're now on 40 grams with a slow increase over time. Their TOF cough, they say, drastically reduced immediately.
Ooh.
They're saying, is this something known to TOFs and as a positive side effect, or is it just purely accidental that it's working with them?
Can you just spell that? I'm just looking at in the BNA.
Yeah,
That's a trade name.
EL,
Yeah.
VA,
BANSE.
NSE. And then it's got brackets.
Ooh, I've never heard of this. Lisdexamfetamine.
Yeah.
It's a prodrug of dexamphetamine, which is speed to the rest of us.
Right.
Right. And it's for ADHD, I suspect. Is that right?
Yeah.
Yeah. Well, that's an interesting observation. These drugs actually affect the nerves. So I'm very interested in that observation. I will let me just look. Oh, it's got a lot of side effects. Cough is not among them. So I'm learning as we go along here.
Okay. Perhaps it's something that we can come back to the next time when we get together again and have another Q&A session.
Well, I'm going to treasure that because that's a very interesting observation. I always say patients are our greatest teachers to the medical students.
Yeah, I learn every day off the kids at school. So yeah, absolutely.
Yeah.
So we'll add that one to the next time. I think so. Probably then, from observation, it's probably just purely accidental that it's improved for them. But at least,
you need to look at these observations and see whether there is a good reason. I think we're going to come on to a question where I think I've made an observation in similar lines to this. Anyway, do go on.
Okay. All right then. So, quick question then: what is tracheomalacia?
Tracheomalacia is floppy breathing tubes. So in some people, particularly some TOFs, but also people who've been cigarette smokers with COPD, what happens is the cartilage gets loose, right? And particularly in the trachea, the main windpipe, right? So the back half of the windpipe is actually not got any cartilage in it, and it flops forward, right? So that actually causes obstruction to the breathing in and out. Okay. So that's tracheomalacia. However, doctors diagnose it far too much, I think. Right? They're looking for the cause of this cough. And tracheomalacia is a described illness. Right? And we do see patients with tracheomalacia. There's no doubt about it. But then they're looking for a real disease which causes the cough. They ignore the fact that there is a disease of cough with this hypersensitivity. So they're looking for a real disease and not the made-up disease that we've got of this cough hypersensitivity. So it can cause breathlessness. It doesn't usually cause a cough.
Okay, that's right. And speaking of breathlessness, as if by magic, we're moving on to the next question. This person has always experienced breathlessness. This has worsened over the last 4 or 5 years. COPD and asthma has been ruled out. Inhalers have been ineffective, worsening symptoms as they affected their voice. Their doctors have basically written them off. Eating a large meal seems exasperate their breathlessness, yet sometimes I can go for a walk without feeling too bad. Can this be related to their TOF?
Yeah, it's caused by their TOF. All right, so cough is the commonest symptom, but some patients get breathlessness. Right? And the breathlessness is the same set of nerves or similar nerves, right? So it's a perception because of hypersensitivity of the breathlessness nerves, right? That's why the tests have been normal for asthma and COPD, okay? But the patient feels breathless. Now, it's not very well recognized by other doctors, but this, they call it dysfunctional breathing. Now, why is the voice altered? Right? What's happening is they have a big meal, right? And we all eat air as we eat food. So the stomach then sorts the air from the food out. And then typically 5 to 10 minutes after the meal, the valve at the bottom of the gullet is told to open and to allow the gas coming up. And so this gaseous mist comes up and lands on the voice box, making the voice alter. You can actually hear it in patients. You can hear the voice change as one of these episodes occurs. And then in some people, they inhale it, right? And that irritates the nerves in the breathing tubes, and they become hypersensitive. So patients will say that they get breathless. First time I observed this was in a gentleman who he was a very sensible chap who had been referred to me by another colleague, and he said, I can hardly walk at all because I'm so breathless. Very sensible guy in his 60s. And so I walked him up and down the corridor, and by the second lap, he was going, and he couldn't breathe. And yet his oxygen level had gone up. All right. So it wasn't the lack of oxygen that was causing his breathlessness. His nerves were being irritated. Now, we mentioned Gefapixant earlier on. That blocks a particular receptor. There is another receptor, very similar, a cousin receptor in the lung, and I thought that an old-fashioned drug called aminophylline, which we know blocks that second receptor, might work. So he'd had to give up all of his activities, more or less. It wasn't quite housebound, but more or less. And I phoned him up a month later. He'd rejoined the golf club and was going fell walking with his wife. So in a group of patients, this receptor is blocked by this old-fashioned drug, which we've been using for years. It's been used for COPD for years. Very unfashionable nowadays because we know it doesn't prevent exacerbations of this illness, but it blocks the perception of breathlessness. So I would try and persuade the GP to give you this old-fashioned drug and see whether it works. But the cause of it is this non-acid reflux going into your lungs and causing the irritation, which in your case is causing breathlessness rather than cough. but they're the same mechanism, different receptors.
Okay, thank you. Next question. Have you ever seen somebody OA-TOF with a portoystemic shunt? And do you see adults or teens on purees? And what are your thoughts on intensive feeding programs? So it's 3 questions there. Sorry.
Yeah. So portoystemic shunt is a abnormal blood vessel which comes from the portal circulation. So when you eat something, it goes into your guts, and then there is a vein that takes it to the liver. That's the portal vein. So what happens in a portosystemic shunt is there is another abnormal vein that goes from the portal vein, bypasses the liver, and goes straight into your circulation. Now, the liver does lots of wonderful things. It does the nutrition bit, but it also cleans out impurities and toxins. So what you're doing by doing this bypassing is you're dumping toxins into the blood, and it can affect people neurologically. So they get very a lot of different strange side effects. It can bypass the liver, particularly if there is existing liver damage. But the commonest one would be in a TOF would be a congenital abnormality. So you've got 2 congenital abnormalities there, one of the esophagus and one of the portal vein. It's often treated by blocking the portal, the abnormal blood vessel. Sometimes they do a procedure in the liver to do that, but I'm no expert in this particular area. I'm just describing what's in the textbooks there. You really need someone who knows what they're talking about.
Okay. Do you see people on purees?
Purees. Well, the dietitians are very keen on this sort of stuff. I'm not sure myself that it makes much difference. See, the problem with a TOF is movement, and I've done, we have a technique called high resolution esophageal manometry, where you put a tube down and get the patient to swallow 10 sips of water and 10 morsels of bread. And then we can see where the abnormality is. And we have all sorts of different abnormalities, and the treatment depends on where that abnormality is. Often it's at the top in the TOF, because that's where the commonest site is of the atresia or anastomosis. So, but sometimes it's down there, and I mentioned earlier on, some people have a hiatus hernia. So, depending on where that abnormality is where you concentrate your treatment. The purees are, the theory goes that they're easier to swallow, but we have people who have very good swallows with bits of bread and food, but very poor swallows with water. And conversely, we have people who have very good swallows with water, but when we give them the bread to swallow, it's very poor. And actually, sometimes you can see the bread sitting on the probe that's down there. So it depends on the individual. I mean, it's a question of sucking it and seeing, but a routine prescription of purees is not good. It depends on the individual.
Okay. So what are your thoughts on intensive feeding programs?
Well, it depends if you're underweight. I mean, if you've got a relatively normal BMI, then that's good. You don't need intensive feeding. There are people who have very poor absorption from the guts, and that's probably a generalized disorder of the gut, right? So a lot of people with a chronic cough, and certainly some TOFs that I've known, they have a poor movement of the whole of the gut. They've obviously got some malformation of the nerves, and this nerve, the vagus nerve, supplies most of the guts. So I suspect that they've had some interruption at the TOF area or the OA area, and so the innervation of their gut is not too good, and it's very difficult to get them feeding. And often they'll do a PEG tube. The PEG tube, it goes into the stomach and allows you to be fed overnight or during the day if you want, from a bag of nutrients. Be careful though, because if you've got a hiatus hernia, for example, the stuff can go back upwards rather than downwards, and then you get worse because it's coming up and going in your lungs. It's not simple.
Thank you. If you want to grab a drink for 2 seconds, I was just going to remind people about, obviously, if they've got questions, just to keep popping them in the chat function. And obviously, I'll keep my eye out on them and keep asking them as we're going through all the other questions. And please don't forget the adult cuppa and chat, which is on Thursday, the 6th of November. So please obviously join that and obviously talk to other people with the same issues or even different issues. Speaking of issues and different issues, how can people come and see either yourself or your team or another specialist up and down the country who, specializes in coughing?
When I went to Hull, which is about 30 years ago now, not quite 30 years, but very nearly 30 years ago, there were a number of patients with TOF. And the reason why is because we had a pioneering cardiothoracic surgeon called Mr. Kevin McGessie. And he did some of the very earliest TOF repairs. And so these patients have come through. And I was handed them because of my interest in cough, if you like. So I've got to know these patients, and I mean, it's been a very rewarding experience seeing them, but not many of my cough colleagues have this experience. So it was a pure circumstance of coming to Hull where Mr. McGessie had been doing the operations. There are very few cough doctors, and if you will be between a rock and a hard place, because the gastro DIs that you'll go and see will not really understand the chest component. And if you go and see the chest component, they don't understand the gastro guys. It's a dreadful silo system in medicine where we have these different organs and forgetting that you're a whole person, and one organ feeds into the other to produce the symptoms. If you get a good consultant, I'm dealing with a lady with a TOF who goes and sees a consultant in Cambridge, and he just said, well, ring me up. And we had a chat over the phone, and we sorted out a management plan in about 5 minutes. So it's really a question of finding the right consultant, whether it's a gastro consultant or a respiratory consultant, and then communicating with them. I mean, I'm happy to, I've got TOF patients that I speak to in Cornwall, further north, up in the frozen north. So all around the country, people will email me, even Wales on occasion. So what you, I'm very happy to receive a referral from the GP, or some people just email me. And I don't want a flood of 100 emails tomorrow, but I'm very happy to just give some simple advice and hopefully liaise with the local consultant who may not understand fully what the problem is.
Yeah, that would be great if they can do that. And obviously they can email the office, and obviously we can help.
Yeah. Obviously, sorry.
With them. Yeah, no, I'm just saying, just adding that in the email the office, and obviously they can then help, and obviously we can also coordinate. If we get lots of questions about the same thing, we can come back to you and ask you, in one email rather than. I'm trying to save you having lots of emails.
Yeah. Yeah, but
Right. So that's the end of our questions that we got pre-sent. We've got 3 which are in the Q&A. The first one is, can tracheal diverticulum, which I understand most people have after TOF OA surgery, apparently it scares anesthetists. Is that true? What is it?
so when you've got a TOF patient, so the esophagus tends to go, there are various different types, as we all know, right? But what tends to happen in the commonest types is that there is a little tube that goes into the trachea, so the main windpipe. So your gullet comes down, and then there's a tube comes out, right? And then the surgeon can join up the bits of the esophagus, but that tube is still left. That's the diverticulum, right? And there's a lot of fantasy about this. If the surgery's been done properly, there won't be an actual hole for things to go through. But there is this funny little pouch. That's a diverticulum, right? It's harmless in my view, right? But, an anaesthetist worry about things,
Okay. So the next question is, I use a saline neb and a PEP, but the GP won't give the equipment for the PEP, which the respiratory physio says it's on the GP to give. Any advice?
Yeah, change the GP. I mean, sorry, PEF is
I don't know. It just says PEP. So
PEF.
it says PEP.
PEP.
So a saline neb and a PEP.
I'm not an expert in these devices, so I don't know what a PEP actually is. There's various devices that people use. A flutter valve is one, so they push a ball back and forth, and it flutters and makes the air flutter within your chest to get the phlegm up. I mean, the question really is how much of the symptoms are due to bronchiectasis or bronchitis, and how much is due to the nerve being hypersensitive. Physios are excellent in general, but they will concentrate on the physical side rather than on the nerve side. So if the diagnosis is mainly bronchiectasis, then physio does help. I mean, there's a recent, actually published this week, a trial of saline nebs in bronchiectasis, and there was no benefit whatsoever.
Okay. They've just added a little bit more, saying the diagnosis is tracheomalacia, and I've also had somebody else put on that PEP means positive expiratory pressure device.
PEEP, positive end expiratory pressure, right? So you got a mask on, right? And that mask blows in the air and it keeps the airways apart. So that is usually a hospital thing. That's not a GP thing, I wouldn't have thought.
Okay.
So it's a mask that you wear, particularly at night, and it blows the air in to keep the airways apart. So it's positive end expiratory pressure. So the end of expiration is when you breathed out, and that's when the airway collapses the most. So you have a positive pressure produced by the mask, and then that keeps the airways open. Whether it does anything, as I said earlier, people tend to overdiagnose tracheomalacia because it's a real disease, whereas the real problem is, in fact, often the coughing.
Okay. And then the final question we've got in the chat is that, we've got another one just popped in. is this person's on PPIs for with a diagnosis of GORD. They're on two different types that don't seem to make much difference. Definitely have hypersensitivity with their throat, and you've described earlier on tonight a lot of their symptoms. What would you recommend?
Sorry, what symptoms are they getting for the GORD?
I don't know. I don't know anymore. That's all they've said.
So treat the heartburn, and as it required, as I said, right? And if they're not having heartburn, don't take the PPI. It's quite simple.
Okay. Okay, that's fine. The person has just put on a, when we're talking about that PEP or PEEP, they've put theirs is pronounced PEP, and and many devices, types of devices like a ping pong ball inside, they blow against, which is interesting. So, thank you for
Yeah,
that.
it rattles back and forth, you see,
Yeah.
and causes a pressure wave in the chest. Whether that works or not,
Okay, and then the last question, because there is just another one come up. This person was repaired at birth with a colonic interposition 65 years ago, so quite a long time ago, and had a gastric pull-up in 1987 when a large piece of colon became very stretched and redundant. I also have severe cephalitis, spine fused from T1-12-5. 5 years ago, I was diagnosed with restrictive lung disease as my chest capacity is now down to 40%. Pulmonology and respiratory have given up on me, and because they're saying nothing else can be done. Any suggestions?
yeah. So what happens when you have a colonic transposition is that over time the colon expands, and so what you have, I've got a couple of patients like this, and the colon, which has been put into place of the esophagus, dilates up, and so you have a bag here basically, and so when you lie down, everything pours into your lungs and so on. I doubt very much whether you have restrictive lung disease. What's restricting you is your chest wall, right? So you can't breathe because of the spinal problems, right? So although they call it restrictive lung disease, your flows are restricted, right? But they're not restricted by lungs, they're restricted by your chest wall, right? The gastric pull through is to get rid of some of that bag of colon that has been put in the way. Any suggestions? Well, your stomach's in your chest, right? So stuff's going to come back up, right? And the idea is to try and prevent the stuff going down the wrong way and giving you chest infections, which aren't really chest infections at all. They're aspiration events. Stuff will come up and go into the lungs. So don't be given lots of antibiotics with it. Don't take any steroids, because the doctors often will give you steroids as well. They are harming you. What to do about it? Well, that drug I mentioned earlier on, prucalopride, actually works on the lower gut. So it may well work on the colon as well, but the colon's in the wrong place, but it will have the right receptors to respond to that drug, prucalopride. So there are a number of agents there. There are other drugs, and it's a question of finding the right drug to suit someone with that problem. I mean, they won't want to operate again because everything will be messed up inside. It will be an absolute surgical nightmare. So I'm afraid that the options are relatively limited, but there are things that can be done with its prucalopride, for example. And if they're making you take PPIs, I'd stop those as well. I would. Anyway, that's a pull. You're an extremely complicated patient, and I'd love to see you, but I can't over the video.
Absolutely. But thank you for that. Yeah, I'm sure they appreciate that. And then the last question, because it is 8 o'clock and we always like to try and finish on time. So this person has a colonized pseudomus and they're coming to the end of a 2-week round of Ciprio to whack it down. They've had another slight aspiration 2 nights ago. Should I ask the GP for another week?
Pseudomonas is a horrible germ which is quite frequent in people who aspirate. Right? So ordinary bronchiectasis, non-cystic bronchiectasis, a good proportion of patients grow Pseudomonas. And that comes from stuff you've eaten that you aspirate. Okay, and then people become colonized with it. So initial colonization or initial infection, we treat with eradication therapy. So that's a prolonged course of ciprofloxacin plus nebulized colamycin. If you're colonized with it, though, there's no point in doing that prolonged. It's a clever drug, ciprofloxacin, but ciprofloxacin resistance is quite common, particularly if you've had repeated courses. So you need to send your sputum off to get it tested. If it is resistant to ciprofloxacin, it's not probably going to work. But these people with this pseudomonas, there's often a zoo of them down there. So one sputum sample will say it's resistant, another sample will say it's not. It depends who's top dog in that zoo of pseudomonas that's in the lungs. And in people with severe bronchiectasis, we have to give them intravenous treatment, and there's quite a lot of that in a fairly common cause of admission to give prolonged courses. We actually put in a line called a passport so that you can get the intravenous treatment at home. So check that the bug is sensitive to the ciprofloxacin. If it is, yes, ciprofloxacin is indicated. If not, I would think if you're having repeated episodes, you probably need to consider having this passport or portacaf in to have intravenous treatment on a regular basis.
Alan, thank you for your time tonight. As always, we much appreciate everybody who gives up our time. But yeah, thoroughly enlightening. And again, as you say, it's always a learning day, and I've always learning things. So thank you for that. And obviously, please, for everybody else, fill in our survey, have a look at our website, like our videos, and obviously come back and meet us when we've got the TOF chats and things like that, or even our next face-to-face event if you can make it. So thank you everybody for joining us. Have a safe good evening, and we'll hopefully see you again soon. Thank you. Good night.